Hello, my name is Beth and I'm going to be your nurse today. We're going to start off by doing a head-to-toe physical assessment. So before I do anything further, I'm going to go ahead and I'm going to sanitize my hands. And what I'd like you to do is I'm going to say 3 words and I want you to try to remember these words. Okay, are you ready?
Ready.
Phone, ball, dog.
Okay.
You got it?
Mm-hmm.
Okay. So first of all, I'd like you to start off by telling me your name.
My name's Stuart Wallstrom.
Speak up a little bit louder.
My name's Stuart Wallstrom.
Good. What's today's date, Stuart?
Today's July 6th, 2016.
Good. And where are you at right now?
I'm at home.
So, as I'm listening to the patient talk, his speech is clear. He's quick to respond to me. Looking at the patient, he's clean, well-groomed, and he's calm, and he's cooperating. So, next thing I'm going to have you do is I'm going to have you close your eyes. Good. Raise your eyebrows. You can open your eyes. Smile, and puff your cheeks. Good. So what I'm just assessing there is cranial nerve 7. Cranial nerve 7 is intact. Okay, next, Stuart, I'm going to have you stick out your tongue. Stuart's tongue is nice and midline, and this is assessing cranial nerve 12. So next thing I'm going to have you do is we're going to have you differentiate between sharp and soft touch. So what I'd like you to do, Stuart, is close your eyes, and I'm going to press an instrument that's either sharp or soft against your skin, and I want you to tell me which one it is, okay?
Okay. Soft. Sharp. 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 Soft. Soft.
Good. So the patient is able to differentiate between soft and sharp touch, and that is assessing cranial nerve 5. So next, I'm going to assess the patient's extraocular movements. So, okay, Stuart, I want you to go ahead and look straight at me. Don't move your head. Follow my pen light with just your eyes. Excellent. The patient's extraocular movements are intact. I did not note any nystagmus with his eye movement. So next we are going to check, and I'm sorry, that is part of assessing cranial nerve 3, 5, and 6. So what we're going to do next is I'm going to take a look at your conjunctiva, and pulling down on your bottom lid, I note that it is pink, moist, clear, there's no discharge, there's no dryness, just as it should be. So we're going to check pupillary response next. So what I'm going to do is I'm going to cover one eye and I'm going to shine a light directly into the patient's left eye. So go ahead and look forward at me. And I notice that as I shine the light into the patient's eye, that pupil does constrict. Go ahead and look at me. And that is assessing a direct pupillary reflex. Now what I'm going to do next is assess a consensual pupillary reflex. So what I'm going to do is I'm going to shine a light in Stuart's left eye, and I'm actually going to be looking at Stuart's right eye to see if that pupil constricts. So I'm shining a light into Stuart's left eye while looking at that right pupil, and it does constrict. Let's check the left. And that one constricts as well. So next I'm going to check the patient's ear. So I'm looking at the patient, I can see that the patient's ears are symmetrical bilaterally. Looking at the skin is intact. I don't note any lesions or bumps. The external canal, I don't see any cerumen. Do you have any pain?
I do not.
Ear pain? Okay. I don't notice any discharge. Let's check the other ear. And same for this ear as well. Any ringing in your ears?
No.
Okay, good. So next we're going to assess the patient's oral mucosa. So I'm going to have you open your mouth for me. Good. Oral mucosa is pink and moist, as well as the palate. Palate is nice and pink and moist and smooth. So I'm going to have you say ah. And when the patient does this, I note that the uvula and the palate rise midline. And that is assessing cranial nerves 9 and 10. So I'm going to check for a patient's gag reflex. And what I would do is I would take a tongue depressor and I would place it against, I would have the patient stick out their tongue. Go ahead. And I would place the tongue depressor on the back of the patient's tongue to check for a gag reflex. I'm not going to elicit a gag reflex in this patient, but that's how I would assess that. So next, I'm going to have you shrug your shoulders against resistance. Good, nice and strong. That's cranial nerve 11 that we're assessing. So next, I'm going to palpate the patient's neck. The patient's neck is smooth, supple, palpating lymph nodes. Next, I'm going to assess the patient's carotid pulses, and we do this one at a time. And that's to prevent eliciting a vasovagal response in the patient. So we check one side first and then the next. Carotid pulse is strong on both sides. Next, we're going to listen to see if we can auscultate any bruits. And what I'm listening for is a swishing sound. I don't hear any on the right side. Listening to the left side, I don't hear any swishing noises as well. So we're going to assess the patient now for any jugular vein distension or JVD. So I'm going to look at the patient's jugular vein. I do not notice any distension either side. If I did, that could be indicative of right-sided heart failure. So I'm going to palpate the patient's trachea. Patient's trachea is nice and midline. We're going to try to palpate for the patient's thyroid. Now, in most instances, you're not able to palpate a thyroid unless that patient has an enlarged thyroid, which in this case, I'm not able to palpate it. So next, we're going to take a look at the patient's skin. I'm going to have you raise your arm up for me. Okay, so I'm looking at the hair distribution pattern of the patient's skin. It's nice and even. His skin color is appropriate for his ethnicity. There's no discoloration. It's nice and warm to touch. It's dry. So what we're going to do next is check for turgor. So I'm just going to pinch a portion of the patient's skin and notice that it snaps back quickly to how it was. Now if I would pinch the patient's skin and it would remain in that position, that's what we call tenting, and that could be indicative of dehydration, which I did not note any of that. So good. Next, we're going to check the patient's nails. And I'm looking for any clubbing, which I do not note. That could be indicative of respiratory issues. His nail beds are nice and pink. There's no cyanosis or bluish color. I press down on his nail beds to check for his capillary refill. It is less than 3 seconds, which is indicative of good circulation. So good. Next, I am going to check the patient's respiratory status. And what I'll do first is I'm going to check for respiratory excursion. So I'm actually going to come behind the patient here, and I'm going to place my hands on both sides of the patient's back, and I'm going to have the patient take a deep breath, and I'm going to see if my hands are move symmetrically to actually test to make sure the patient's breathing is symmetrical. So Stuart, I'm just going to have you lean forward just a hair here, and then I'm going to have you take a deep breath. One more. Excellent. My hands move symmetrically. The patient's chest is symmetrical. So noticing the patient's diameter, the patient's AP diameter to transverse should be 1 to 2, which it is. We're going to palpate for any tactile fremitus. What I'm going to do, Stuart, is I'm going to place the base of my hands against your back on both sides. When you feel that, I want you to say 99, okay?
Okay. 99, 99, 99.
Good. Now, I didn't palpate any tactile fremitus. If I would have, that could be indicative of pulmonary congestion or some kind of fluid in the lungs. Next, we're going to take a listen to breath sounds. So we're going to start by listening to the anterior chest. So Stuart, every time you feel my stethoscope against your chest, I want you to take a nice deep breath for me. Good. The patient's lung sounds are clear bilaterally on the anterior portion of the chest. Next, we're going to listen posteriorly. So again, Stuart, when you feel my stethoscope, go ahead and take nice deep breaths. What I'm listening to first is listening for bronchial breath sounds, which are the high, loud, pitched sounds. Next, I'm going to listen for bronchiovesicular breath sounds. And these are moderate tone breath sounds that are heard over the main bronchi. I was listening to the patient's vesicular breath sounds, which are heard over the peripheral lung fields. Patient's lungs are clear bilaterally. Oh, and vesicular breath sounds are low and soft, if I did not mention that. So while I'm back here, I'm going to check for costovertebral tenderness. What I'm going to do is I'm going to palpate for that. So, any pain or tenderness with that, Stuart?
No.
Okay, good. So we're going to move on to the respiratory assessment, or excuse me, cardiovascular assessment. And just looking at the patient here, I note that there's no thrills, pulses, or anything noted to his chest. Also, with his respiratory status, I don't believe I said that. Looking at the patient, his respiratory rate, his breathing is regular, it's unlabored, he's not in any respiratory distress. So, I apologize. Back to cardiovascular. We're going to palpate for the point of maximal impulse, which is the fourth intercostal space midclavicular line, which is here. So next we are going to auscultate the patient's heart tones. So I'm first going to listen for the aortic valve. Next I'm going to listen to the pulmonic valve. We're going to listen to the tricuspid valve, and last the mitral valve. I don't hear any murmurs, rubs, or gallops. I use the diaphragm portion of my stethoscope to auscultate this patient's heart sounds. Now, if I was suspicious for any adventitious sounds, gallops, murmurs, rubs, I could use the bell portion of my stethoscope to listen. But I did not hear any adventitious sounds. So the apex is where you would hear the sound, the heart tones, the loudest. We're going to check for pulses now. I'm going to have you raise your arms out like this, Stuart. Good. And I'm going to check the patient's radial pulses bilaterally. Nice and strong. I would say that's +2. And same, +2 bilaterally for the patient's radial pulses. Next, we're going to check for the brachial pulse. +2. And +2. +2 bilaterally for the brachial pulses. Next, we are going to assess the patient's pedal pulses. So Stuart, if you could raise your legs for me. You can rest it down on my legs. Good. So we're going to check the patient's pedal pulses, which is found at the top of the foot. And they are palpable bilaterally, strong. I'd say +2. Dorsalis pedis, or excuse me, posterior tibial pulses, which you could palpate between the malleolus and the Achilles tendon. And they are +2 bilaterally. Next, we're going to assess the patient's abdomen. So Stuart, I'm going to have you lay back for me, please. We're just going to raise your shirt slightly just for this portion of the assessment. Okay? And looking at the patient's abdomen, it's nice and toned, smooth contour, skin is warm, it's dry. We're going to take a listen, or excuse me, I don't notice any pulsations or peristalsis. If I did, this could be indicative of obstruction or some other intestinal issue, but I do not note that. We're going to next listen to the patient's bowel sounds. We're actually going to start in the right lower quadrant portion of the patient's abdomen, and we're going to follow along the line of the large intestine. So. After auscultating the patient's bowel sounds, I note that they are normoactive in all quadrants. Now, if I did not hear bowel sounds, I would have to wait and listen for a full 5 minutes to state that the patient does not have bowel sounds. So, next I am going to listen to the abdominal aorta. Where's your arm for this? And we're going to listen for the renal arteries, the iliac arteries, and the femoral arteries. Okay, good. So what we're going to do next is I'm going to palpate the abdomen, and what I'm doing when I palpate the patient's abdomen is I'm assessing for any masses, any enlarged organs. Pain when I palpate, Stuart?
No.
No, good. And I do not note any masses or any large organs, so good. I'll have you sit up for me, Stu. And I'm going to assess the patient's lower limbs. I'm going to observe them. So, looking at the patient's legs, I note that the hair distribution is even. His skin is warm, it's dry, his skin is not shiny, it's not taut. There's no discoloration that would be indicative of peripheral vascular disease. So next we are going to palpate the legs and the feet. We're going to be assessing for any pitting edema, which I do not observe or note. So I'm going to have the patient, we're going to test the patient's motor strength. So what I'm going to have you do, Stu, is I'm going to have you push down against my hands. Good. Point your toes up. Patient's